5 moments for hand hygiene: before touching a patient, after touching a patient, after exposure to body fluids, before aseptic procedures, and after touching patient surroundings. When beginning hand washing, use an alcohol spray.
And now I beg to see you dance just one more.
Step 1. Rub hands palm to palm. Step 2. Rub the back of your palm with the back of your hand and interlace fingers. Don't forget to do vice versa. Step 3. Rub hands palm to palm with fingers interlaced. Step 4. Massage your thumbs. Step 5. Use the tips of your fingers to rub your palms. And step 6. Use the back of your hands to rub them.
Just one more day.
And finally, no jazz hands.
Dance for me, dance for me, dance for me, oh. I never seen anybody do the things you do.
Good morning, sir. My name is Kaylin Ferrara and I'm a first-year medical student. Who are you?
I'm Thomas Jason.
You can come in and take a seat.
Thank you.
The examination starts the moment when the patient walks through the door. When the patient comes in, you look at their facial expressions and you look if you can see distress or any signs of discolorations. Afterwards, you look at the patient's race, age and sex, whether they are well nourished and if they have any signs of cardiac distress or like cardiac problems. So, Mr. Tom, as you walked in, I saw that everything looks fine, you look well and healthy, and then the next part of our general examination will be Jack.
Before performing a general examination on a patient, it is important to introduce yourself and ask permission to perform the examination on the patient. Good day, I'm a first-year medical student and I have washed my hands and I would like to ask your permission to perform this general examination on you.
Yes,
is that
please.
right? Thank you, sir. Now we can examine the patient more specifically using the acronym JACL. Firstly, you should check the patient for any signs of jaundice. Signs will present themselves as yellow discoloration of the patient's skin or mucosa due to an increased bilirubin concentration or hyperbilirubinemia. Firstly, you should assess the general appearance of the patient, their features, for any yellow discoloration in the patient's face or hands, their legs. As you can see, our patient appears fine, and we can move to examining the eyes. This is done by asking the patient to look up. So would you please look up? And this may be a little bit uncomfortable. So gently pulling down the patient's lower lid to reveal the color of the sclera, which, as you can see, is a nice white uniform color and is not indicative of jaundice. Moving on, the next place you can check jaundice in a patient is by asking them to open their mouth. So would you please open your mouth? And gently pulling back their lower lip to check the color of their buccal mucosa, which in our patient is a healthy pink color and not indicative of jaundice. While the patient's mouth is open, so would you please open again, you can check the patient, let me just see your teeth, thank you, for any signs of dental caries, which would be indicative of infective endocarditis.
The A of JACL is for anemia. Anemia is caused by iron deficiency and can be checked for by examining the conjunctiva and the nail beds. I'll now examine the patient's conjunctiva and nail beds. Ma'am, I'm Thomas, I've washed my hands and I'd like to ask to examine you for anemia.
Yes, that's fine.
I will pull down the patient's eyelid and ask her to look upwards. Please, if you can look upwards. I can see that her conjunctiva is a nice pink color. I'll now ask for her hands and examine the nail beds and see that they are also a pink color. In anemic patients, both the conjunctiva and the nail beds would be a very pale color, indicating anemia. There's also no splintering of the nail beds, indicating infective endocarditis, and no spoon shape of the nail beds, which would indicate calincmia.
The third step of JACL is checking for cyanosis. Cyanosis is a condition in which the patient's skin or mucosa appear slightly bluish tinge as a result of decreased oxygenation in the blood. Central cyanosis can be checked by asking the patient to open their mouth. So would you please open your mouth and stick out your tongue? Thank you very much. And examining the tongue for any signs of blue discoloration, which is not seen in our patients. Moving on, we can check for peripheral cyanosis by examining the patient's hands and feet, for specifically their nails, for any signs of blue discoloration, as well as the patient's lips, which also appear to be a nice pink, healthy color. While you're at the patient's face, you can examine their cheeks for any signs of mitral facies, which would be shown with rosy cheeks with a slightly bluish tinge.
Moving on, we'll be checking the nails for clubbing, which is the increased soft tissue in the distal parts of the fingers or the toes due to a variety of reasons, including infective endocarditis. To check for clubbing, we perform the Shamrock window test. Could you please hold your breath? So essentially, we're looking for the diamond-shaped window or space between the nail beds, forming the hyponychial angle. The loss of this angle is indicative of clubbing. It is very important to repeat this process with all 10 fingers or toes to confirm the diagnosis. So as you can see, the diamond-shaped space is present. Another method that we can use to test for clubbing is to rock the patient's nail beds. The sign for clubbing will be a clearly rocking nail bed. See your thumb. So as you can see, the patient's nail is nice and firm, and therefore it can be concluded that the patient does not present with clubbing.
I'll be looking for signs of edema. So sir, could you please take off your shirt and lay on the bed? Thank you. I have washed my hands, and do I have your permission to do the examination? Edema is the accumulation of fluid in the body tissue and cavities. You can check the skin of the hands, feet, ankles, and sacrum for signs of edema.
There are two types of edema, pitting edema and non-pitting edema. If after applying pressure for 5 seconds to the swollen area, a cavity forms, this is indicative of pitting edema. I will now be examining the distal tibia for signs of peripheral edema. I will apply pressure with my 3 middle fingers for 5 seconds. You will do this bilaterally for 5. As you can see, Mr. Jessup does not have any pitting edema. For lymphadenopathy, you use the pads of your middle and index finger to palpate for lymph nodes. You can palpate the neck, axilla, inguinal, and elbow area for lymph nodes. So sir, could you please sit up, please? I will now focus on the neck area. So I will start by feeling the pre-auricular lymph nodes, the posterior auricular lymph nodes, then the tonsillar, the submandibular, the submental lymph nodes, and moving to the back of the head at the base of the skull, the occipitals. Now I'm going to move down to the neck. So you locate the sternocleidomastoid muscle, and then at the front you can feel the anterior cervical chain of the muscle, and at the back of the muscle, the posterior chain, cervical chain, and then for the deep cervical chain, you should try and feel underneath the muscle. Finally, I will feel above the claviculae for the supraclavicular lymph nodes. For the cardiovascular examination, your patient should be lying at a 45-degree angle in the supine position, exposed from the waist up. There should be adequate lighting, and as the examiner, you should position yourself at the right-hand side of the patient.
So the aim of examining the pulses is to assess the rate, rhythm, character, volume, and radiofemoral delay. The different pulses of the body include the carotid, brachial, radial, femoral, popliteal, posterior tibialis, and dorsalis pedis pulses. In the case of femoral and popliteal pulses, the patient's pants will be removed given that the patient is comfortable and has given consent. Now, the rate is measured over a period of 30 seconds and is then multiplied to calculate the beats per minute. Then, without the patient being aware, for another 30 seconds, his respiration rate will also be measured. Both sides, left and right pulses, need to be measured to compare the readings. Now, the normal rate is between 60 and 100 beats per minute. A slow heart rate or bradycardia is any reading below 60 beats per minute, and a fast heart rate or tachycardia is a reading above 100 beats per minute. I will now be examining the patient's radial pulses, which determine rate and rhythm. I have washed my hands. Do I have permission to perform the following examination?
Yes, please.
It has been determined after assessing both radial pulses that the patient's pulse rate and rhythm is normal, and also the patient's respiration rate is normal.
I will now be assessing the jugular venous pressure. I just need to make sure that the patient is lying at a 45-degree angle and that there's adequate lighting, of which there is. The JVP primarily tells us about the right side of the heart, to be more specific, the right atrial and ventricular pressures. You'll ask the patient to slightly tilt his head to the left side to locate the sternocleidomastoid muscle, and you'll ask the patient to slightly flex forward to show the prominence of the muscle. The muscle extends from the mastoid process, which I will mark here, to the sternal head, which attaches to the sternum, which is right here, and to the clavicular head, which is right here. And as you can see, this forms a small internal triangle where we will locate the point of highest venous pressure, which is right here, which lays medial and deep to the sternocleidomastoid muscle.
Hello, sir. Do I have the consent to measure your JVP?
Yes, please.
Okay, great. When measuring the JVP, we're going to look at the following landmarks. Will you just turn your head to the left, please? We're going to use the sternal angle, which is beneath the sternal notch, about here. And we're also going to use the highest point of venous pulsation, as Melinda already pointed out. It is in fact here, she marked it. I will now measure the vertical height in centimeters from the sternal angle all the way to the venous pulsation, and the sternal angle is the 0 or reference point of the heart. I will place one ruler on the sternal angle, like this, and the other from the point of highest pulsation, parallel to the floor, perpendicularly to the ruler. Okay, this is about 2.5 centimeters, which is good. A normal JVP is no more than 3 to 4 centimeters, and if it is more than that, the JVP is raised. The character of the JVP is described as having a complex waveform, which is visible but not palpable, and it will notably change when the patient changes position or with respiration. The JVP is also oblique when pressure is applied to the neck, but increases when pressure is applied to the abdomen.
An important thing to take note of is that the anterior part of the chest overlying the heart is called the precordium. There are a number of important surface anatomical landmarks that one needs to keep in account when performing a cardiovascular examination. These include the sternal notch, which is a depression located at the base of the neck where the clavicles attach immediately to the manubrium. As you trace your finger vertically downwards, you will find the sternal angle, also known as the angle of Louis, where the second ribs meet. Below that is the sternum body, and further downwards you will find the xiphoid process, which is the pointy end of the sternum. The midclavicular line is an imaginary line which cuts the clavicles on both the right and the left side in half vertically downwards. The final landmarks that one needs to take into account are the axillary lines. So would you please lift your hand up? The first axillary line is the anterior axillary line, which is the line that runs vertically downwards from the axillary fold. The next axillary line is the posterior axillary line, which runs vertically downwards from the posterior axillary fold. The patient's final axillary line is the mid-axillary line, which is the line found between the posterior and anterior axillary line.
I'm going to start with the inspection of the precordium. Sir, do I have permission to do inspection? My hands are already washed. The first thing to look at is our patient's skin. Then we're going to look at his color in relation to the rest of the body. Is it pale, is it blue, or is it too red? His looks quite normal. We're also going to look at his skin for any signs of scars or lesions to indicate any previous cardiac surgeries he might have had. He only has one scar on his left shoulder, which is indicative of his previous shoulder surgery. He does not have any other scars or lesions. He also does not have any signs that show he might have a pacemaker or a defibrillator along the pectoral region. The other thing to look at is his chest shape. The normal chest shape is supposed to be twice the width and once the breadth. His is normal because he also does not have a pigeon chest, a Harrison Falcus chest, nor a barrel-shaped chest. The last thing to look at in terms of inspection is the inspection of any visible pulsations over the precordium, more specifically for the apex beat. Important landmarks include the sternal notch, the angle of Louis. Across that is the second rib. Below that is the second intercostal space and his left mid-clavicular line. In order to locate his apex beat, which is defined as the most lateral and inferior point of cardiac impulse where it is palpable over each contraction, we're going to start from the second rib, and then from the second intercostal space, we are just going to go down to the third intercostal space up until we get to the fourth and then to the fifth intercostal space. Once we get to the fifth intercostal space, we're just going to move 1 centimeter medial from the left mid-clavicular line where the normal apex beat should be located. It is important to know that in 50% of the patients, the apex beat is not clearly visible. However, this is normal. I'm just going to ask you to just breathe in for me. If we look over the apical area, we can just see there is a visible pulsation in this area, which is where the normal apex beat should be located. I'll be moving on to the palpation of the apex beat. In order to palpate for the apex beat, I'm just going to move down the mid-clavicular line and just put the flat palm of my hand over the apical area. Please breathe in for me. The apex beat can be felt. I'm just going to use the tip of my fingertips to feel for the point of maximum impulse, just 1 centimeter from the left mid-clavicular line. A normal apex beat is supposed to just gently lift the palpating finger.
Good day, sir. Do I have your consent? I've already washed my hands. Do I have your permission to palpate you?
Yes.
So to start off with, I'll begin to identify the sternal notch. I will then find I will trace my fingers down the manubrium, finding the angle of Louis, to which the second or the heads of the second rib attach. I will then find the second intercostal space, which is where the aortic area is located parasternally. I will then find the corresponding second intercostal space, which is where the pulmonary area is located parasternally. I will then trace my fingers down, third rib, third intercostal space, fourth rib, fourth intercostal space, and this is where the tricuspid area is located, once again parasternally. Then I will go down, fifth rib, fifth intercostal space, and then I will locate the mid-clavicular line. This is where the mitral area is 1 centimeter medial towards the mid-clavicular line. Now I will palpate using the flat portion of my hand to palpate for any palpable thrills. A palpable thrill can be felt as a small vibration on the palm of my hand. This is significant of turbulent flow over the heart valves. I'm palpating the mitral area, the tricuspid area, the pulmonary area, and the aortic area. We can safely say that the patient has no palpable thrills.
The third part of the cardiac examination is percussion. Percussion is used to define the cardiac outline. When percussing, we start percussing from the second intercostal space down into the fifth intercostal space, down the midclavicular line. We use one's hand of our middle finger into the intercostal space and the other hand's middle finger on it to percuss. Hi, sir. I've washed my hands. Will you please give me the consent to touch your body?
Yes, please.
Thank you. So we've got the sternal notch, the manubrium, and down the manubrium we have the hook of Louis, the sternal angle. Next to it we have the right rib. And beneath that we have our second intercostal space. When percussing, we percuss from resonance to down. So here we go. Second intercostal space, resonance. Third rib, third intercostal space, resonance. Fourth rib, fourth intercostal space, resonance but slightly down. Fifth rib and fifth intercostal space. Still a bit resonance there, and if that's the case, we're going to move medially and then percuss again, which is down. But for accurate percussion, one has to percuss from the anterior axillary line down into medially into the sternum, still in the fifth intercostal space. Resonance, resonance, resonance of the slightly downwards, and down.
Today I'll be auscultating the precordium. The main purpose of this is to listen to the heart sounds in order to identify any abnormalities of the heart valves. So I have washed my hands. Do I have your consent to perform this examination?
Yes.
The first sound I'll be listening to is the S1 sound, which is also known as the lub sound. This is found in the mitral and tricuspid areas and coincides with the start of systole or ventricular contraction. At the same time, I will place my left hand on the patient's radial pulse to assess whether there is synchronization between the radial pulse and the ventricular contraction of the heart. I will begin by auscultating the mitral area, which is located at the apex beat, or the fifth intercostal space, 1 centimeter medial to the left midclavicular line. I will then move on to the tricuspid area, which is located at the fourth intercostal space on the left sternal border. I'll begin by locating the sternal notch, then making my way down to the sternal angle, the second rib, second intercostal space, the third rib, the third intercostal space, the fourth rib, the fourth intercostal space, the fifth rib, the fifth intercostal space. I will then identify the midclavicular line and then make my way 1 centimeter medial towards the mitral area. I can therefore conclude that the patient's S1 sound is loud and low-pitched, and this indicates a normal closure of the mitral and tricuspid valves. There is also synchronization between the radial pulse and the patient's ventricular contraction of the heart. The next sound I'll be listening to is referred to the S2 sound and is also known as the dub sound. This is located in the pulmonary and aortic areas and coincides with the end of systole or ventricular relaxation. I will begin by auscultating the pulmonary area, which is located in the second intercostal space on the left sternal border. I will then make my way to the aortic area, which is located in the second intercostal space on the right sternal border. I can therefore conclude that the patient's S2 sound is softer and higher pitched than the S1 sound. This indicates the normal closure of the heart valves.
So they say, dance for me, dance for me, dance for me, oh, oh. I never seen anybody do the things you do before.